Okay. So good evening, good afternoon, good morning. So across the globe. So this is Dr. Gauhar Afshan. I am the professor of anesthesia and pain medicine working at Aga University, Karachi, Pakistan. And I would like to introduce my co-chair, not the co-chair, is the chair of the WFSA committee, Clare Roques, and I will introduce herself for the welcome note. So here is introduction. So she is a consultant in anesthesia and pain management in the UK. She has been working for the last 15 years. She's a chair of the WFSA Pain Management Committee, and she's a member of WFSA EPM Steering Committee. And she has led many essential pain management education workshops across the world. So Claire, here is the mic for you.
Thank you very much. Thank you. I mean, I actually am no longer working in the NHS, but I have done for over 25 years. So thank you very much. Welcome to everyone. Thank you for coming on this Saturday from all over the world, I think. And thank you very much to our organisers and, of course, to our panellists and chairs for these sessions. As Dr. Afshan says, I'm the chair of the Pain Management Committee of the WFSA. That's the World Federation of Societies of Anaesthesiologists. And the WFSA, as many of you will know, is a network of societies that brings anaesthesia providers together. And our committee, our pain committee, is dedicated to providing support, training and education for clinicians who specialise in pain management with a particular focus on resource-poor countries. We're currently focusing on advocacy in order to raise awareness of the importance of managing acute or short-term pain. As I'm sure you're all very well aware, acute pain is very common and often under-recognised and under-treated, and this has significant effects for both the individual and wider society. Furthermore, around 80% of the world's population lack access to controlled medications used to treat moderate to severe pain. And we'll be addressing many of these issues in the this truly global webinar that's coming up. We'll be addressing many of these issues. So I'm going to hand back now to Dr. Afshan, who has organised this event so brilliantly and will be taking us all through the next steps. Thank you.
Thank you very much, Claire. So we all know that this is the second webinar of our series, according to the WFSA committee. So title is about managing acute pain, a call to action. Today we have two very sessions, the panel discussion, and one is moderated by Dr. Afreen. I will introduce Dr. Afreen soon. The title of her panel is about core standards for managing acute pain, a global perspective. And then another session is about the moderated panel discussion by Dr. Shakaib Chugtai, the evolving challenges for acute pain services across the world. And we have a very, thrilling, very well-known panelist who was working in the pain management, pain medicine for years and years, and Dr. Afreen will introduce later on. So first of all, I would like to introduce Dr. Afreen. Hello, Dr. Afreen. So Dr. Afreen is Associate Professor of Anesthesiology, is a clinical educator, Alfred Medical School's Brown University, Chief Anesthesia Section, Director Interventional Pain Management, and the Providence VA Medical Center, past President of Rhode Island Society of Anesthesiologists. So Afreen, mic to you. Afreen is a moderator of our session. Very thrilling title, the core standard for managing acute pain, a global perspective.
Hello, thank you, Dr. Afshan, for that introduction, and also thank you to WFSA for inviting me to participate in today's webinar on such an important topic. As Dr. Afshan said, we're going to talk about the global perspective on the core standards of managing acute pain. I'm going to introduce you to our esteemed panelists. I am also going to encourage the members of the audience to please submit their questions in the chat box, in the question chat box, and we will endeavor to answer all of your questions at the end of our discussion. I'm going to start to share my screen and start with the introductions here.
Can I just interrupt and remind everyone that we're recording this session and we're going to release it afterwards? So I'd like to make that clear to everyone.
All right, so let me introduce you to My first panelist, Dr. Eman Nada. She's the Associate Professor of Anesthesiology, Chief of Regional Anesthesia and Medical Director of the Pain Services at the Renaissance School of Medicine at Stony Brook University. Dr. Anna Schwartzmann, Associate Professor of Anesthesiology at the Universidad de República Montevideo, Uruguay. She's the pain and palliative care expert. She's also the coordinator of the Acute and Multidisciplinary Pain Unit at the Hospital de Clínicas Montevideo. She's been the past president of the Latin American Society of Regional Anesthesia. And Dr. Mary Cardosa, she's the visiting consultant, pain specialist at the Hospital Selayang, Malaysia. She has trained with Pam McIntyre at the Royal Adelaide Hospital and also set up acute pain services in KL Hospital in 1993. She set up other APSs in other Ministry of Health hospitals in Malaysia as well. She did a pain fellowship at the Royal North Shore Hospital in Sydney and has set up multidisciplinary pain clinics in Malaysia back in 2000. She's the current president of the Malaysian Association of the Study of Pain. My slides are not moving. Let me see. So I'm going to start the discussion off with basically making a comment that pain management is an area often overlooked in the medical education. And given the current opioid crisis, particularly in the United States, this is even more apparent. It is through such discussion and that we can actually increase physician knowledge and our ability to recognize and understand the unique needs of each individual patient and enhance our understanding on utilizing a multimodal team approach to pain management. And with that, I'm going to jump right in and ask Dr. Schwartzmann to maybe comment on why is it so important to treat acute pain?
Good morning to everyone. Thank you for this invitation. It's an honor for me to be here. And when we talk about the importance of acute pain management, we have to know that pain afflicts millions of people all over the world, that is still untreated. We don't treat well the pain. We have to know that it's the most common reason for admissions in the emergency department. Pain is the most common reason for why the people consult in the emergency services. It is also one of the most common reasons for post-surgical hospital and readmissions. It increases the cost of hospital care or the cost of health in general. And it is an important risk factor to develop chronic pain. Undertreated acute pain may develop chronic pain, which could be a pathology, a real discapacitant pathology for the people. So we have to also know that acute pain is present in all the inpatient settings. Almost all the people who are hospitalized has pain. Pain can be associated with trauma, with surgery, and also with acute medical illness. And we have to remember that some people suffering from chronic pain, like cancer or others chronic pain, also can experience acute exacerbations or may develop an unrelated acute pain.
Thank you, WFSA, for the invitation. As Dr. Schwartzmann started, she covered most of the points, so I'm just going to reiterate some points. So treating pain is humane, and it's one of the human rights. We cannot leave the patients in pain in the hospital, and even like we cannot negotiate the patient's dignity and asking for pain to be treated. It's unpleasant surgical experience if the patient is having uncontrolled pain, and that can result in the patients not coming for surgery the next time or delaying their procedures, resulting in complications and negative consequences before they can present. As all of you, as anesthesiologists, we know this very well. Unrelieved pain results in exaggerated and prolonged neuroendocrine response, resulting in tachycardia, hypertension, increased work of breathing. We all know of this, hypercoagulability, decreased immune surveillance, and this can result in the patient who's extremely sick, this can result in important consequences like myocardial infarction, like respiratory issues, like pneumonia. These are all important. Also, treating the acute postoperative pain is important in helping the recovery and shortening the length of stay in the hospital and reducing the admission to the ICU, which are some indirect costs of the treatment. Also, treating pain can result in patients' early mobilization, avoiding DVT, avoiding respiratory issues, atelectasis, and respiratory complications. Another point of the acute pain is some of the acute pains are not related to surgery, and those can sometimes be the sole reason of the patient's admission, like sickle cell crisis, like ischemic pain. So it's very, very important to manage those pains. I think those are it's very important to manage the pain for the above reasons. And for the first reason, it's a humane right of the patient.
Very good, thank you.
And I just want to summarize saying that what the patient remembers from their hospital visit is whether their pain was well treated or not. So I think it's actually from the patient point of view also very important to treat that pain.
Excellent, very good. Let's jump right into the next question. What are the core aspects of acute pain management? Dr. Schwartzmann, I think you're muted.
Sorry for this. Well, the cornerstone to treat pain is the assessments of pain experience. We have to listen empathically to our patients, to listen to patient experience. You know that pain is a subjective and pain is an experience. So we have to take 2 minutes to listen to the patient and to legitimize patient's pain. If the patient said he's having pain, we have to believe him, and we have to be close to our patient to recognize the pain and then start the next steps. We have to give to the patient the best level of relief safely. So knowledge, experience, and empathic and availability to attend the pain as soon as possible are the cornerstone for treating pain. So I divided why this is important for patient. Next slide. Yes, perfect. Reasonable pain management is a human right, as we have just mentioned. We have to listen to patient's report of pain and how patient is living this experience. We have, as Dr. Nada has just said, avoid biological consequence of the biological effects of pains. And we have to know that not provision of necessary pain relief could have potential legal liabilities. So if we have colleagues that are not able or not willing to ensure adequate anesthesia to our patients, they must refer them to a colleague who has this expertise. We must, it's our duty to treat the pain adequately. So we also have to remember that patient with pain is in a psycho-emotional state very special. Maybe it's uncomfortable, but the people with pain can also be desperate. So we have to have tools to help them. Next, please. What happened with us? No, sorry, medical staff. What happened with us? Well, we have now enough knowledge to treat acute pain, but we have to spread this knowledge. That's why we are here today, to tell the world that we have enough knowledge to really relieve the pain. We have to improve the education in pain since school medicine programs. And we have to improve our model treating pains. We are teach to treat pains with biomedical model, and biomedical model is not centered in improving the quality of life. So sometimes we have to use the biopsychosocial model, that is the one correct to treating pain, especially in chronic pain. Medical staff in general are afraid of the use of opioids for two reasons that we are going to speak now, but they are for the abuse and the side effects, and many times for the restricted access to opioids. So we have to work on it. We, as medical staff, usually doesn't use the non-pharmacological and pain management tools that are very, very useful. So we have to use them more. And these are two very important concepts. There is no reason for not treating pain. No, there is no even one reason for not treating pain. We have to treat pain. And we have to know that this phrase is totally false. Some pain is unavoidable. This is not true. We have to treat, and we can treat every kind of pain. Next, please. What's happened with our institutions? Well, in the institutions, the adequate pain management reflects high quality healthcare, of course. The relief of people suffering, as we have said now, is a primary humanitarian aim. Treating pain has an impact in the global institutions' outcomes. Many accreditations in international organizations require standards for pain management, and unreasonable failure to treat pain is viewed worldwide as a poor medicine, unethical practice, and an abrogation of a fundamental human right. Next, please.
So we know how Joint Commission has made, a while ago,
yes,
vital signs. So you're absolutely right. Go ahead.
Yes. Well, so we have to use a systematization to treat pain. One very useful tool is the Essential Pain Management Program of WFSA and Australian and New Zealand College of Anaesthesiologists. That is a simple system to manage pain that consists in a workshop that could be done for nurses, for medical students, and for doctors, anesthesiologists or not anesthesiologists. And this program allows us to recognize, analyze, and treat pain in a simple way, but very effective. So we have to look for tools, and I think this is a very useful tool.
That's excellent. Thank you.
Thank you.
Did anybody else have any comment on that, Dr. Cardosa?
No, I think we can go on to the next. I think she's covered it very well.
Very good. So what are the barriers in treating acute pain within each of your clinical settings? I'll open it to all of you, each one of you at a time, to discuss that, because I'm sure each of our clinical settings is just slightly so different, coming from various backgrounds. Dr. Nada, would you like to start?
So first, I'm going to start with the patient. There's a concept that pain is inevitable of their disease or their surgery, and complaining about pain might distract the surgeon or the physician from treating the cause of pain. And some patients feel like complaining about pain is a sign of weakness, and they should be tough up, and they shouldn't complain about that. Also, some patients worried about the analgesics and the side effects and the fear of addiction in case of opioids. And also the treatment can be costly, and sometimes, not always. So patients are worried about that. For the professionals, I think the main reason here is the inadequate knowledge. And this is not among anesthesiologists. Maybe the anesthesiologists are the most educated about pain, but there are some other specialties don't know much about pain. They know there is pain that exists, but what's the mechanism or how can we treat it, or the importance of pain is not something in their high priorities.
That's such an important point you make, right? I think we all agree on that, the lack of knowledge.
Yeah, and usually pain, education about pain is not part of the medical curricula in most of the medical schools. Another thing also, the professionals, they don't assess the pain really well, or they don't look at the pain as a global in the background of the patient's disease. Also, other factors like some systems don't reimburse pain management. They consider it part of the surgery. So there is no motive to treat the pain, and also restrictions of controlled medications in many countries, and cost of the treatment to the hospital and to hire an anesthesiologist and to create a pain service. It can be costly to some hospitals.
Dr. Schwartzmann, would
just to add some comments to what Dr. Nada said. The barriers are very important, that we know the barriers, that we check the barriers, so we can start on knock these barriers down. So again, remember the lack of knowledge or the misconceptions about pain management, but our colleagues are all the healthcare workers. There's also a lack of evaluation or inadequate assessment of pain intensity and efficacy of the treatments that we use with the patients. Also, sometimes there is an absence of transitions between different analgesic techniques. There is lack of information to the patients about the consequence of pain not treated properly. I think many of our patients didn't know that if they don't treat adequately acute pain, they could develop a chronic pain. There's, as we have repeated many times, fear of the use of side effects and the use of opioids. And this is another point, that treat pain is not a priority, nor for healthcare, even and not for government institutions. They have another priorities, especially in our countries, in low and middle income countries, where we have another indications of health, like maternal mortality, that are more important rather than treated pain. So there are not politic plans to treat pain. I think this is important. Next. I think the other, the one behind this one, thank you. So to summarize, in levels, we have the patients that are lack of information. We have the surgeons. The surgeons, many of them do not manage postoperative pain, and they do not manage the concept of chronic postoperative pain that is being a problem now all over the world. Nurses are afraid of administering opioids, so they also sometimes doesn't help us. The physicians, the rest of physicians, not the anesthesiologists, I hope, they do not have enough knowledge to treat pain. And in the institution, we have difficult to access to the medication, and our institutions also has another priorities different than pain. So I recommend you to read this article that was published in Anesthesia and Analgesia in 2007 that talk about pain management, a fundamental human right. It's a very, very good article that summarizes all these things. Thank you.
That's excellent. Thank you.
Can I just
interrupt?
No, I'm so sorry to interrupt. Can I just encourage everybody who's a participant to put any question you have for the panelists in the Q&A box. You should have a Q&A option. Put any questions in there and we'll have a look through them and try to get them to our panelists when we can. So just to encourage everybody to ask a question if you have them. Thank you. Sorry, guys. Carry on.
Great, thanks. Dr. Cardosa.
Yeah, so organizational structures are also important, and so I will next slide. I will just point out two more barriers, which is more at the organizational level or institutional level, which is if you don't have standardized protocols for acute pain management, sometimes it's not well done. So it's good to actually have, that's one of the roles of the acute pain service, to implement standardized protocols, not just for management, but also for observation and for how to deal with any kind of complications that could occur as a result of your pain management techniques. The other one, which I think is very important, is a multidisciplinary approach. Very often we forget about using a multidisciplinary approach when we manage acute pain. Especially, we think that it's just important to give morphine, you know, to give the PCA button to the patient and nothing else. And in fact, the role of the physiotherapist, the role of the nurse, and the role of the patient themselves is actually very important. Communication between members of the team, alerting the APS team when there's problems, but also for the surgical team and the surgical nurses to know what they can do before the acute pain service team arrives to make the patient more comfortable or to deal with complications is actually very important. As I mentioned, non-pharmacological techniques and patient education are also some of the barriers that can lead to poor pain management. And the other barriers in my country are obviously similar. Lack of knowledge in healthcare professionals, and healthcare professionals also having a lot of myths like, you know, we shouldn't use too much morphine and things like that, even in acute pain management. So thanks, Afreen. We can go to the next question.
You made some great points there, Mary, right? You talked about the multimodal approaches, non-pharmacological approaches, especially here in the US. With the opioid crisis, we're going, the pendulum's shifting the other way now, where we really stressed upon pain being the fifth vital sign, and everybody got opioids, and now all of a sudden, you know, pendulum's shifting again, saying no more opioids, and maybe it's swinging too far, but that's another discussion for another day. So let's talk about, while we're talking about restricting opioid use, right? Dr. Nada, you're probably most familiar with it in the US, with the crisis we're facing. How has it impacted your practice?
So I wanted to start first with just the basic principles for the use of opioids. Certainly, it's the gold standard for acute pain management. And we still, I think we should be using morphine, whether we use other strong opioids like fentanyl and oxycodone. Often is an institutional preference or because of availability, but morphine really is the gold standard. And because it's acute pain and healing will take place, only short-term use is needed. So we give the patient as much as they require for that short period of time. And so the principle that we use is what the reverse WHO ladder. From step 3, we can step down to step 2 and then step down to step 1 when there is severe, moderate and mild pain. Using strong opioids at step 3 for severe pain, weak opioids like codeine or tramadol at step 2 for moderate pain. And we don't need to use any opioids, non-opioid analgesia, NSAIDs and paracetamol at step 1. And it's preferable, of course, when we discharge patients to at step 2 or step 1, especially in our countries where we don't have a lot of good controls for strong opioids in LMICs. But in my country, we do discharge some patients with strong opioids, but we limit the dose to 3 to 5 days maximum. And we give them an early follow-up at the pain clinic to continue the de-escalation to non-opioid analgesia as the wound heals. So I think Nada will go on to talk about the US, the situation in the US.
So from what I see in the literature, there is disparity to access to opioids in the world. Some countries like North America, we have all the kinds of opioids and we were very liberal, although they're still controlled and restricted, but the system still recognizes their importance and patients can go home with opioids and these things. And at one point of time, it was encouraged to be used to the degree that, as Dr. Siddiqui mentioned, we have reached it to a point where it was really unfavorable, and we reached it to what we call now the opioid epidemic in the US. However, opioids are very important medications, and they are double-edged bullet, yes. They are good and they are bad at the same time. So in the world where people don't have access to opioids, usually the reasons are the systems or excessive fear or all the outdated system and inadequate clinician education, and people still holding the idea of these opioids are only for cancer pain, or they can cause addiction and we can't use them. And also inavailability of these opioids, although these opioids are not usually expensive. Morphine is very cheap. However, the companies, big pharmas don't want to invest in that because it doesn't make that much of a profit. So they tend to market for the more expensive opioids, which usually these countries are of limited resources, and they find it very difficult to buy those expensive ones. As Dr. Cardosa mentioned, morphine is the gold standard. However, there are multiple forms of opioids that have different potencies and different side effect profile. So in some countries, because of unavailability of the controlled medications, the society worked on having availability of cannabis as a pain management tool. And this resulted in another problem, which is the illicit use of cannabis. And from the scientific point of view, cannabis for pain management is still not very strong medication, and the evidence is not very strong about its use. So opioids, they have their own place. They should be used judicially, and there shouldn't be used openly or shouldn't be restricted altogether, as happens in some countries.
That's great, thank you. Let's move on to the next questions. We talked about multimodal pain approaches, right? And a lot of us as anesthesiologists are using peripheral nerve blocks to move away from the opioids. What do you do to educate your patients in dealing with pain when the block fades, Dr. Nada?
So that's a very important question. Okay, there are types, it depends on the type of surgery. Some surgeries, like the orthopedic surgeries, are very painful, and rebound pain is very well known. For me, I put everyone on multimodal analgesia, regardless if they had a block or no block. So the medications are in their system before the pain comes back. And multimodal includes a blanket of non-steroidal anti-inflammatory medications if there is no contraindication, a blanket of acetaminophen or paracetamol, as it's called in some other countries. Usually there are very few contraindications of acetaminophen, and opioids, PRN, as needed. So everybody gets the multimodal. Everybody has the nerve block. And also I found very useful the use of Decadron, perineural Decadron. Some experimental studies has found it affects the rebound pain. When the pain comes back, it doesn't come as bad as without the Decadron in the mixture.
Do you have a magic number, Dr. Nada, for your perineural dexamethasone?
I have what?
Do you have a magic number dose for your?
I usually use 4 milligrams of Decadron, and at the same time, it helps with the nausea and vomiting.
Yes.
Like instead of giving it IV, it works better giving it perineurally.
Excellent.
Yeah, and also the use of long-acting medications like bupivacaine is longer than ropivacaine. Ropivacaine is longer than mepivacaine, and if you have liposomal bupivacaine, that's even better. And also you have breakthrough pain medications just in case. As needed medications, PRN, IV morphine, or IV hydromorphone, or whatever.
All right, so Dr. Schwartzmann, back to you. do you have any guidelines for, Dr. Cardosa mentioned SOPs and having them established. Do you have any guidelines or an SOP to treat acute pain that one could use and share to establish an acute pain service? And maybe Dr. Cardosa can jump in since she's experienced in setting some of this up already.
Yes, sure. But we have to know that the implementation of a service of pain is not an event. It is a process. It is a process that must include the measurement and the periodic analysis of its results. So we have some key points when we talk about service of pain. We have to have a designated specialist that is available 24 hours a day, 7 days, to access in cases of severe acute pain. This could be with the same anesthesiologists that the main part of the team of the hospital, or with an external service, but we can do it with the people who is on duty in this moment in the hospital. We have to know that to treat acute pain appropriately, we have to assess, to have a right assessment of pain. So we have to measure pain in movement and in rest. This is very important. We have to get the cooperation with other physicians, surgeons, and nurses to develop pathway to achieve our goal. Our goal will be the mobilization and the rehabilitation of all of our patients. Nurses are very important. They are the cornerstone of our service of pain. So we have to help them. We have to make continuous instance of education with nurses. We have to make our protocols all with a cost-effective model. We have also to educate our patients and to monitorize the treatments that we indicate. And it's very important that the service of pain has periodic audits of its performance to know if we are doing the things well. And it's very important to see if our patients are satisfied with which we are doing. Next, please.
Afreen, can I interrupt, Afreen?
Of course.
So Afreen, I'm getting questions in the question answer box, and I would just like to ask very brief 3 questions to your panelist, if you don't mind.
Of course.
So before concluding the session, so first question is to Anna. It is about asking acute pain in ICU. Who should treat acute pain in ICU?
Well, in ICU, usually we have trauma patients. No, it's the most common reasons for why they're call us. So we have the structure in the service of pain, and we go there and see the patients. We apply our protocols. Usually, our protocols are made together with other specialists. This is ideally that we make our analgesic protocols and everybody agree with these protocols. Otherwise, it's very difficult. But maybe we indicate a medication and then we go away, and then they don't use this medication because they are not agree what we are suggesting. So the protocols are fundamental.
Okay, thank you. So
I think, can I just add? Can I just add?
Yes,
Because
please.
I think the question also asks whether it is, how people should be referred to the acute pain service, whether it should be routine or whether it should be on a referral basis. In my hospital,
in ICU.
No, not really. It says, and when ICU identifies the patient. So I think every patient should have the benefit of an acute pain service, but that's not possible. Every post-op patient is not possible, practically speaking. So usually it's the anesthetist, but the surgeon should also be able to identify the patients who require acute pain management by the acute pain service after surgery, and that's why I think having a team approach and talking to each other all the time from the beginning, even before the surgery, is actually very important.
Okay. So another question is about the EPM. Another question is about EPM, and I would address anybody would answer. So this is about the scope of the EPM in the lower middle income countries, and what are the prerequisites to start this program in any country, in any institution?
Yeah,
I can.
Yes.
Go ahead.
Yeah, I can talk of this. So like this means like as I understand the question is starting acute pain service, right?
It's EPM program.
No,
Essential
EPM,
Pain Management Program.
the training program. EPM is the essential pain management that is actually available as a 8-hour in-person course, or as a 8 hours or 4 hours. You can shorten it to 4 hours, but there's also a online module available now for 2.5 hours. And maybe Claire or Gauhar, we can put it in the chat so that the audience can have a look at the link to the EPM online. I think it's a very good module, and anybody can use it. And the requirements is that you are just there to organize a group, and you get in touch with, if you go to the EPM website, or you can contact the WFSA as how you got to attend this webinar. We can give you more information on whether if you are interested in running EPM in your institution. We have done it virtually by Zoom. We have done it face-to-face, and you can also get your people, your staff, or your students to do the online version.
So who developed the EPM? WFSA?
It was developed by two anaesthetists from Australia and New Zealand, Dr. Roger Gook and Dr. Wayne Morris, who's now president of WFSA. And it's now a program that has been adopted or endorsed by both WFSA as well as IASP, the International Association for the Study of Pain. But there is an EPM committee that actually oversees the running of EPM in the various parts of the world.
Very good. Did you have any other questions, Dr.?
Yes, one more question, Afreen. So this is about should nurses be allowed to prescribe medication other than opioids to decrease the burden on doctors?
I don't know about the rest of you, but in my opinion, I think nurses should be advocates for our patients. They should be able to guide us physicians. They're there, the patient at the bedside more than we are, and they can certainly give us the feedback. But I would not propose that nurses should be allowed to prescribe. I leave it to the rest of my panelists to either agree or disagree. What do you guys think?
So I think like pain management is like any other medicine specialty. It needs good knowledge of the patient, of the physiology, pharmacology, of the pathology. And I think that's like, that needs years of education in medical school. So that's why I think it's like, they can assess the pain, they can give suggestions, they can give feedback to the physician, but prescribing medication needs a lot of education.
I see Dr. Schwartzmann and Dr. Cardosa also shaking their heads in agreement. Correct?
Yeah.
Any other questions there, Dr. Afshan?
I think this is the last question because we are running short of time. The last question is about any fellowship, scholarship, any sponsorship for starting acute pain service in lower and middle income country. Anybody? Are you aware of any fellowship, scholarship, small program to start acute pain service in
I can answer to that. The IASP does give out developing countries educational grant, and you can use that grant to educate, to do the education that's necessary for your hospital staff, as well as particularly the nurses, but also the doctors, and use that opportunity to draw up your standardized protocols, as well as how you're going to treat these patients and why it's necessary to treat patients. So you can apply. It's available on an annual basis, maximum of $10,000 US, and it's very competitive because we only give out about 5 grants per year, but there's more than 40, 50 applicants, but you go to the IASP website and you have to be a member. So you go to IASP. I will write the link for you in the chat.
Excellent, Mary. So Afreen, can you please conclude the session so we can go for a next session, please?
I just wanted to say this has been such a wonderful discussion. Thank you to my panelists. I appreciate all the time that you've put into this. It has been wonderful with your expertise. I think this collaboration is so very important. And one of the points that you just asked Dr. Afshan about, how do you set up fellowships? The grants are great, but I think alumni such as us need to go back to our country and give back. So anytime I make a trip back to Pakistan, I try and do a little mini workshop on some type of nerve block if I can, teach them something, leave them with something. So I think this has been wonderful. Thank you. I appreciate it.
Thank you very much, Afreen, and all the panelists. So now we are going towards the second panel, and the second panel will be moderated by Dr. Shakaib Chugtai, and I feel honored to introduce Shakaib Chugtai. She's a specialist in anesthetics and pain medicine, Broomfield Hospital, Mid and South Sussex, NHS Foundation Trust, UK. A very energetic pain physicians and young pain physicians. And Shakaib, now mic to you.
Thank you very much for the introduction, Dr. Gauhar. Good morning, good afternoon, good evening across the globe. Just going to add a few words before I introduce the panelists. So we talk about acute pain, and we need to talk about opioids as well. There's been a lot of discussion. Opioids have been central to acute pain for the last many years. They continue to be so still. Now, even though that's right to a certain extent, doesn't mean that if you've got a cupboard full of a colorful mix of opioids and you've got a nurse or a trainee doctor 24 hours ready to dispense those, that's an ideal acute pain service. There's been a lot of change. Just to quote a few facts, in America alone, between 1990 and 2015, the painkiller prescriptions tripled from 75 to 220 million per year. In the year 2019, 300 million prescriptions were written for opioids alone. 10 million people misused prescription opioids in 2020, and that's up from 2 million in 2000. So that's an increase of about 500%. 1.5 million people were diagnosed with a pain condition that required an opioid prescription. 70,000 people died from drug overdose last year. Now that's every day about 200 people, and that's about 8 people every hour. 70,000 people used heroin last year, and that's up from 42,000 in 2019. About 40% of opioid overdose deaths involved a prescription opioid. In the UK alone, about 4 million surgical procedures took place last year, and they found out 6% of patients were using opioids 6 months down the line. So an acute pain service is not only about opioids or having nurses. It's patients' beliefs, their expectations, their knowledge about their disease, resources, yes, and clinicians' knowledge about diseases, their limitations, and obviously alternative therapies. Now, it was a wonderful discussion earlier by Afreen and the panelists talking about acute pain. There has been a lot of change over the last 20 years. I think we're heading in the right direction, but it is a major challenge. So to talk about these changes, we have our panelists. They're heavyweights of anesthetics and pain medicine. It's a pleasure to introduce them. First, we have retired Brigadier Dr. Asif Kayani. He is from Pakistan, President Society for Treatment and Study of Pain. He's been actively involved in developing pain medicine curriculum with the College of Physicians and Surgeons of Pakistan. He's initiated the pain center in the combined military hospital in Rawalpindi, one of the first centers to be recognized for pain training by the CPSP of Pakistan. He is actively involved developing the pain, like I said, the pain curriculum. Then we have Dr. Gaston Nyirigira. He's a senior consultant anesthetist and pain specialist at Rwanda. He's the president of the Rwanda Pain Society. He's a member of the IASP Developing Country Working Group. And he's been instrumental in setting up the acute pain services in Rwanda. And third, not least, we have Dr. Abdullah Kaki. He's from Saudi Arabia, a professor and consultant of anesthesia and pain medicine, director of the Pain Clinic Faculty of Medicine at the King Abdulaziz University, president and founder of the Saudi Society of Pain Medicine at Saudi Arabia. And he's also initiated the Saudi Abode Fellowship Program of Pain Medicine. So my first question would be, if it's all right, Dr. Kayani, from you. So what do you see the current culture of acute pain setup provision in a developing country such as yourselves? Is it ideal? If not, how can we improve it?
Thank you so much, Dr. Chugtai. Am I audible? Can you hear me?
Yeah, yes, you are, please.
Yeah. Okay. In fact, this current status of acute pain management in developing countries, especially in Pakistan, I can talk more about the situation in Pakistan. It's not ideal at all. We can say that very few hospitals, even major hospitals, have a structured program, have a well devised or well standardized program, and those few hospitals that include Aga Khan Hospital and the big hospitals like Shaukat Khanam and the Shifa International, they're all private or semi-private hospitals, and all these hospitals we can say well organized, and they are also CI certified, which are university. Our problem is mainly with the public sector hospitals, even the teaching hospitals. So we do not have yet a well-organized acute pain management service, and we have been trying to develop such service in our military hospitals, but that is still it's just, we can say that in the initial stages we are doing something, on the basic model of managing acute pain in the anesthesia recovery units, post anesthesia recovery units, the PACUs. And that is also the basic sort of model, which is nurse-based or physician supervised. Typically, we can say that the model suggested by Raval, but no comprehensive acute pain management service yet exists. And we appreciating this problem, but we suggested that, I still suggest that all the programs like anesthesiology training programs, like fellowship and training and anesthesia training by CPSP, they should it should be incorporated into their curriculum. But that curriculum I do not have much price on that in the modification of that curriculum. I keep on advocating and to the people, but we are not yet able to get it incorporated in the curriculum, because that is the only we can say a definitive method or methodology or approach. So once we have in the curriculum that all the training centers where anesthesiology fellowship is trained, they should have a well-organized acute pain service, and only then they will be recognized for training by the College of Physician Surgeons. If that is incorporated in the curriculum, only then we will have acute pain service in many more, at least big teaching hospitals. But the rest is all depends upon the sensitivity of the anesthesiologist or the surgeon who cares for his patient postoperatively, or sometimes the patient may be more concerned about postoperative pain, and somebody may take it. But there is no, at least in our country, there is we are not satisfied with the present state of affairs.
No, thank you very much for that, Dr. Kayani, which leads me to the next question. So I'm going to ask Mr. Nyirigira. Lack of resources, that's been touted as a major factor in provision of an ideal acute pain service. What's your thoughts on that?
Yeah, thank you very much for this. It's true, and it's really unfortunate, and makes feel bad. And however, something has to be done, and most of effort done, especially in my case in my country, and it might be similar to some of the countries in the same same settings. It's just to focus on the advocacy, as I always mention, and this will involve whoever is part of decision making. Here to know hospital administrations, and once you get a buy-in and regular support, this will be really important to that challenge. And then involve the pharmacist, because having everything that goes with the medications, equipment, and consumables go with the pharmacist. So having a pharmacist on board is one thing that is strong to make this advocacy. And then involve the clinical department heads, which will strengthen the advocacy too. Having procurement staff involved too, this is one also of the solutions. So from this strong group, this can go to even to high institutions. This start from the hospital, and then can go to the level of the Ministry of Health. I mention this because some of the countries don't have country societies for pain to make a stronger advocacy on this. So it may start from the institution by whoever is really committed and with the passion. So because here it's not easy in these settings to have to think about the PCAs, for example, in acute pain. But of course you have to choose the best of what we have. And then with the prescriptions of medications, for example, and other things that are needed, to report incidents, like regular reporting the lack of medications, for example, and then, of course, starting by having standardized protocols. And what is missing on the protocols, then we have to report the incidents. So it's a chain of things that we have to combine and do. Focus one by one. It's not an easy way to go, but something has to be done. Thanks.
No, thank you very much. Thank you. Dr. Abdullah Kaki, so my question for you would be, so like we've discussed, an ideal acute pain service is not about a nurse or a doctor standing on top of a patient's head with morphine in his hand. It needs to start with patient awareness as well. So tell us a little bit more about the acute pain provision awareness amongst patients, the culture in society. And it's so different. We've seen this time and again. It so differs between a doctor and a nurse as well, who are working together. What are your thoughts on that? Why do they differ?
Okay, thank you, Shakaib, for this question. I'd like to thank Claire and Gauhar also for inviting me to be part of this scientific activity. Now, let's take the patient in different parts of the world. And here I'm not talking about highly developed country. Although now the world is a small village, with the social media and the communication. But there's certain part of the world where pain is, especially the acute one, is a simple one, short duration. And most of the time, the patient will accept it. He will never ask for treatment. And this is a problem. We know that the human right, necessitate adequate treatment of his pain. So we need to change this culture. We need to change this belief. On the other hand, some of the patients are afraid that the opioid use will make them addict. This is another issue that we have to change among patients, especially the parent of some children. The child will suffer after his surgery or after the trauma because the parents are worried that you give him some opioid, he will stop breathing, or you're going to cause harm for him. Now, that's regarding the patient. I know that it's been touched by my colleagues, so I'm not going to repeat what they say, but I just touched the point that it's not covered. Now, on the other hand, for the doctors and the nurses, or for the medical staff in general, now, if we consider all countries among the world, I'd like to remind you that there's some country where anesthesia is given by a technician or a nurse, not by a doctor. So don't expect somebody like that to look after the pain after the surgery. We have to educate them actually, and to make them ready to manage the patient pain. Now, at the same time, the nursing in the developing country, in the low income and middle class country, she's overwhelmed, or he's overwhelmed with work. You know, some nurses, they're looking after 10, 20 patients. So don't ask her or ask him to go and give morphine for this patient or start the NSAID for the other one. So this is another major problem here. And of course, there's priority. Always there's a priority in this part of the world. Most of the administration, they consider pain as a low priority. When you talk to him, he said, look, I have a lot of endemic. I have to get rid of malaria and TB before you ask me to treat the patient pain. But for the patient, pain is number one. And of course, considering the pain for the patient as number one, we have to concentrate on that. And we have to find way to deliver the knowledge there. Now, for anesthesia doctor, as my colleague mentioned, not all of them, they are great in managing pain as well. You know, because for other specialties, especially the surgeon, it might not be included in their curriculum. They finish the school, they know that pain is only somatic and visceral. You cut, it causes pain for 3-4 days and disappear. So we have to educate those people. We have to educate our physiotherapists, our technician, all of them we need, because they have a wrong belief, and we have to change that actually. And I always recommend that we need to introduce the pain curricula in the undergraduate of all medical health service, not only doctors, nurses, technicians, paramedics, medical alliance, whatever it is. Just they need to be educated about pain, because now with the social media, at one point, the patient will ask for that. Why I don't have proper pain control after my surgery? And we have to be ready for that. I hope that I answer your question.
No, definitely do. Thank you very much. And it is so important because we need to see everyone's pain as different. And if a person says he's in pain no matter what period. So, Dr. Kayani, you've been heavily involved in introducing the pain medicine curriculum in anesthetic training. And you've briefly touched upon that previously when you talked. Why do you think it's so important? Can you hear me, Dr. Kayani? All right, so we'll go to Dr. Nyirigira.
Yeah, I'm unmuted. Oh, okay. Can you hear me now?
Yes. Did you hear me?
Yeah. So, yeah, as it has just been commented that we cannot leave this responsibility of management of acute pain to the nurse, and the anesthesiologist has to take this responsibility. But for that, to take that responsibility, we must first, in my opinion, we must first ensure that our anesthesiologists, during their training programs, during their curricula, they are actually sensitized and trained about the management of acute pain also. They should not be trained in just giving anesthesia, like inducing anesthesia, maintaining anesthesia. Then once the patient is recovered, and they think that our responsibility is over. So we have to give them that responsibility and the training that your responsibility is not yet over, because you have to manage the acute pain, which can be that has to be managed. That has to be planned before you even induce anesthesia, that how to manage the post-operative pain. And during anesthesia, after anesthesia, what different techniques or drugs have to be incorporated for that particular patient, so that the patient stays free of pain after many hours after surgery, maybe it is 24 hours. So to train that, to train the anesthesiologist and to give him that responsibility, and they should be, we have to train that anesthesiologist. It should be part of the curriculum, and then that for that extra service which he has to even be performing, there should be some rewards also. Maybe some monetary reward that if he's taking some extra responsibility, then there should be a mechanism where his services are appreciated and as well as they are compensated.
Right. Thank you very much. My next question is for Dr. Nyirigira. Can I also ask the audience if you have any questions to just put them through, and we'll ask our panelists. Dr. Nyirigira, there's been a lot of talk about multimodal provision of pain relief. Lots of talk about the WHO letter as well. Multimodal pharmacologically, as well as non-pharmacologically as well. So talk to us a little bit through that. Just medications, blocks, non-opioid therapies, non-pharmacological therapies. What's your take on that?
Yeah, that's an important subject to discuss on. I will always talk about my case in my country, and this is very interesting because especially in acute pain, will be different to chronic pain, because I have met patients with a lot of medications that they have taken before they meet us and in pain clinic, and then to decrease or to take them off from those medications is really difficult. So we adopted in acute pain, especially post-operative pain, with different options, using ice compression, some were using heat compression, early physio, early ambulation, distraction and social support, like having a parent, especially in kids, in the pediatric patients, having that support around them, which has shown the impact on reducing opioids, reducing medications they have for pain. And then in our setting, to have local regional analgesia, that some places they don't have people to perform that, they don't have consumables, they don't have, they can't afford that. And even if for some patients, because of the covering insurance, it's not affording that. So that's one of the challenges. And then for chronic pain, we use the other modalities like heat, alternating with ice, depending on what they have, specific exercises to their pathologies, diet control, psychological assistance, and but some of it's really interesting in LMIC where even it's challenging to get ice, for example. What if they don't have a fridge? You know, that things that they can't have access to ice, and so we try to maximize, to contextualize the decision making when we decide on medications. And one of the things we focus is to discuss with the patient, and then give the possibility, the opportunities options, and then they have to choose together, and then they can have access to that pain relief. So it's really challenging, but the role of non-pharmacological measures is really important. We try to use in post-op, for example, we try to use 24 hours opioid, like multimodal approach, with morphine, PRN, and other analgesics like paracetamol if it's not contraindicated, and NSAIDs if there's no contraindication. So we use them for with cautions. And then we see, because we do on regular basis the pain around, and then we can follow up them if they how much they have taken in terms of opioids. So we target at least 24 hours. If they have taken it, PRN, we expect to have pain control, and then they can go to physio, they can go to early ambulation, they can combine with other non-opioid medications together with those ice, like ice, heat, whatever, it depends on the case. So it has shown a very good impact on their pain, but still the problem, because when they go home, and the problem comes when they're in the setting where they can't find those other alternatives. Yeah, so these things of polypharmacy in chronic pain is really a big problem in our settings, because we get patients before they have consulted a lot of doctors giving medications. So they have created that dependence that seems to be difficult to overcome or to control in their pain clinics. Yeah. So the important thing is for the pain warriors, that's how I call them, the pain warriors, just to take time and educate patients at the beginning, which is really important. They have sense, understand the concept of having a multimodal analgesia and especially non-pharmacological approach.
Yeah,
thank
you very much. Thank you. Dr. Kaki, nobody can learn unless and until there's research. What do you think about the scope of research in causing awareness, in developing newer techniques, and overall in acute pain service provision?
Yeah. Thank you, Shakaib. Research is an important contribution to the progress of acute pain management, because that's the way we know whether what we are doing is right or not. Is it effective or not? So conducting research, if you are planning to go for the prospective, randomized, double-blinded, controlled type of research, it's extremely difficult to do in pain, because, most of the ethics committee won't approve that. But we'll do any research. I always say, do any research, whether retrospective, observational, coherent, whatever it is. We need to have some idea. Now, the problem of conducting research is the financial support. Unfortunately, the support for research is limited in most of the countries, especially in the low and middle class income. So such country, research is not a priority for them. And while most of the patients suffering from pain are in this part of the world. So we have to follow whatever the other recommended. Now, for example, we were talking in the first panel about the nurse role in the management of acute pain. We know that in the Scandinavian country, actually acute pain is managed by a nurse. Yeah, they are managing acute pain. If you go to Sweden, Denmark, or Norway, they are the one, because they are highly educated, they have a backup from the doctor. But here we cannot say that. We cannot come to part of the Middle East or Africa or Asia and say that, because they are not yet well prepared. Now, research is important. We have to develop that. We have to create some sort of income to support research. I know that neither the WFSA nor the World Health Organization nor the Asif is supporting research so easily. They have some budget there, but you have to produce a lot of effort to get that money. And conducting research also is not that easy, because the patient, they are not aware about that. So if you are planning to do a research on a patient, he might refuse. You don't have any support to do the statistical analysis or the research assistant prisms to collect the data and follow the patient. So research, unfortunately, in the whole world is not that great. There's certain people, they are trying their best to do the research, and we appreciate their contribution, but we need to work more on that, especially in the pain, whether acute or chronic.
Thank you very much. Thank you. One of the last questions before we take questions from the audience, and this is directed to all of the three panelists here. When we talk about evolving changes, where do you think we were about 15, 20 years ago in your respective countries? Where do you think we are now? Has there been progress? Do you think there's a long way to go? What are your thoughts on that? Let's start with Dr. Kayani, please.
Yeah, talking about 15, 20 years back, even anesthesia was very, we can say, quite a primitive practice here in Pakistan. But now things have changed a lot. They may not be ideal as we can compare it with any other developed country. But still things have improved a lot. Overall, the anesthesia practice has become more safe and more trained people, more qualified people are there. And at the same time, now we are at least discussing these things, like we are discussing a lot how to manage acute pain. At that time, we were nobody was even talking about it. They're just talking about anesthesia or safe anesthesia or how to reduce the mortality and morbidity associated with anesthesia. So now we are through that phase. We are doing all sort of advanced surgeries like transplants and cardiac surgeries, and doing it safely. And now we are, in fact, we have the you can say we come to that stage where we can think of managing pain even in the post-operative period, all sort of acute pains. And we are discussing, but not yet. We have yet to go a long way to have a well-established acute pain service if we specifically talk about the acute pain. But we are moving towards that. We are in the direction, and hopefully, if we keep on working on this agenda, we will achieve our goals. Maybe, if not shortly, maybe over at the end.
Thank you, Dr. Kayani. Dr. Nyirigira, same question for you. Dr. Kaki, if you'd like to answer this, please, for us.
Yes. Now, to answer your question, actually, there's a great progress. In the last 50 years, there's significant improvement in the management of acute pain. We still didn't reach the ideal situation. We're all familiar with the study came from the United States in 2015, where 80% of the patient after surgery suffer from moderate to severe pain for the first 2 to 3 days. And this paper coming from a highly developed country. So just imagine another paper coming from a third world country. So we have a progress. Now, I always say now with the COVID-19 has a great advantage on the management of medicine, actually. I don't look to the negative side, to the positive side, because it introduced the idea of the digital era. And now with the digital area, the communication between doctors, it would be much, much easier. And we have to utilize that to educate those people that are totally unfamiliar with acute pain. It's not an excuse now that we allow any human being on the planet Earth to suffer from pain. We should start managing that. There's a great progress, but we're still facing the problem of poor income among government, not only patient. And this, of course, is an obstacle that we have to find a way to solve that. And of course, lack of knowledge and education is another main problem that we have to work on it. Thank you.
Thank you very much. We've got a couple of questions from the audience as well. So the first question is, can nurses lead and run an acute pain service in developing countries? Before I put this forward to the panelists, I'd like to answer this myself as well. Flat answer, no. You can decorate it as much as you like. I've been trained by brilliant anesthetists and pain medicine people, Dr. Gauhar, Afshan, one of them. You you cannot run an acute pain service without nurses, but you would need to take the ultimate responsibility. Here as well in the UK, I know there's been talk about acute pain services being run by nurses in developed countries, and you talked about them being run in Scandinavian countries as well. Here in the UK, yes, they are our eyes and hands and feet. However, the ultimate responsibility has to lie with either a pain specialist or an anesthetist. That's my take on it, but I'd like you to add to that as well. Dr. Nyirigira, if you'd like to talk about, what do you think about that?
Yeah, thank you. You're right. You can't run an acute pain service without nurses. This has to be a multidisciplinary team, and that multidisciplinary team, everyone has to commit and has to be engaged in that, because how much time do we have to go like in every area just to look at the patient? Nurses do the job. Nurses are always with patients. They always look at the patient. They always report. They always document. They always go around and test and assess pain and then react. So, but I know if you have a very good team, including nurses, and having focal points in each unit of nurses, someone who is looking at that, someone who is following up that, and having a multidisciplinary team, including physio, including nutritionists, including psychologists, all of those things, those people, they can help you to be close to patients. And then when you plan to do the regular pain round, they have an idea of how patients are coping with the pain or are being managed with pain. And then you keep educating. So education about pain is something that continues. So the role of the focal point in the unit is to keep track on new nurses or new members of the team, to make sure they are trained on that, to make sure they understand the protocols, to make sure they understand how to assess patients' pain, and to make sure they comply on the set protocols in the wards or everywhere, at emergency, in PACU, everywhere. But someone has to stand for it and then lead the team. Yeah.
Thank you very much. And just last brief question, role of ketamine, Dr. Kayani, in acute pain. Dr. Kaki, if you'd like to take that as well. Role of acute pain.
No problem. Just a small comment on the nursing. Nobody can deny the role of nurse in acute pain management. Now, we cannot provide the whole service. It depends on the situation. What are the facility in the medical center? What are the type of patient we are managing? Now, I know that in certain small towns in Africa, the only medical staff providing service is a nurse. I cannot come there and say, no, you are a nurse, you cannot give the patient any painkiller. We have to tailor it to that situation. I know that in the Scandinavian, I was the one mentioned that. Yeah, they are highly developed, the nurses are highly educated, and they have a backup from doctor. But in order to initiate that worldwide, no, it's impossible. That's impossible. Anyway, ketamine, it has a good role. We know that in the subtherapeutic doses of ketamine, it has a good analgesia, and we could initiate it as a multimodal therapy. If you want to, especially if the patient is on a chronic opioid use, is a chronic pain with a chronic use of opioid, then ketamine will be a good substitution here. And we usually start with a small dose. I always say 50 mic per kilo per minute. Either you titrate it up or down, depend on the response of the patient. But ketamine is a great drug and has a good analgesia, and in a small doses, subtherapeutic, the side effect is limited.
Yeah, thank you very much. In terms of if you've got any limitations with infusion pumps as well, we do give them orally here in our settings as well. as a PRN basis, you could titrate it to 3 times a day or 4 times a day as well. Thank you very much. I'm just gonna.
Thank you very much. Can you please conclude, Shakaib? Thank you very much. Can you please conclude the session? So we just want a take-home message from Carolina.
Yes, please. So thank you very much for everyone who's joined us. I think what we've, in a nutshell, acute pain provision needs to start not only in the hospital, but pre-hospital as well, with patients' belief, their expectations, their knowledge about the disease process, resources that are available to us, alternative therapy, the doctor's knowledge about pain relief, disease process. It has to be a multidisciplinary approach. There's no way you could have a doctor stand on top of a patient's head and provide pain relief. It needs to involve pharmacists, physiotherapists, nurses, doctors, the patients, the surgeons. There's a lot of role of research. There's a lot of scope of research as well. I think it's come to a point we've learned initially pain medicine used to go hand in hand with anesthetics. It's a whole different branch. We've now separated chronic from acute pain as well. We need to learn more. The more we learn, we find the more difficult it is to treat pain. But thank you very much. I think this session is going to go a long way in helping people in developing countries as well as developed countries to know a little bit more about pain and how to treat it. Back to you, Dr. Gauhar.
Thank you very much, Shakaib, and all the panelists. So I would like to now invite Ms. Carolina Heilerock-Lohr. She is a WFSA program director, anesthesiologist, intensive care physician. She's also interventional pain physician, worked in the Condaminos Médicos de la University, Honduras. So Carolina, one of my favorite Carolina. So please hand over to you.
Carolina, you're on silent.
Sorry for that.
That's okay.
Okay, thank you. Thank you. Thank you for the opportunity of being part of this webinar. This is a call for action for acute pain management. And I may say I remarked some conclusions, like 4 or 5 conclusions for both modules. And as director of programs of the WFSA, I've been answering some questions about the fellowships and all the resources available for the EPM and all this pain management resources that also we commented during the program. And thank you, panelists. Thank you, moderators. Thank you, WFSA Pain Management Committee. Thank you, Clare and Gauhar, for this excellent webinar. And maybe I should say 4 or 5 points that I would like to remark of these 2 modules. One of them is that, of course, education is a priority. Education to everywhere and to everyone. So that is one of our commitments of WFSA, because we are very aware of this global health, public health issue. And it's everywhere, not only low and middle income countries, also high income countries suffer from this situation. And also, well, pain, as you said, is a human right. To treat pain is a human right. So we should be very aware also of this. And although it's a global issue, we must also try to tailor the strategies in each region, because in Latin America, for example, we have opiophobia. In the United States, at our north, in our continent, it's opioid crisis. So we need different strategies to relieve this global public health issue going on. Well, I will thank you very much, and not and to finish, the last but not least, I would like to invite you on behalf of the WFSA the World Congress of Anesthesia 2024. That's the 18th World Congress of Anesthesiologists in March from 3 to 7, 2024 in Singapore. As you can see, here is the call for abstract. It's open and will be open from May to July. That's the deadline. And we are all invited to participate. We are expecting 1,000 abstracts. So please go on with your residents, go on with your hospitals, and all of us right there in Singapore. So I kindly invite you to attend. Thank you very much.
Can I just say, I've just in the chat put a link. If you want to give us some feedback, we'd be really interested to hear what you thought about the session today. And also, if you want a receipt of attendance, then you can request that there as well. Thank you.
So thank you very much, Richard. With this conclusion, with the remarks from Carolina, we would like to conclude this second webinar. Hopefully we'll meet in 2020, next year, 2023, for a third webinar. So thank you very much for all the moderators, the panelists, or WFSA committee administrators. Thank you very much. Good night, good evening, and good afternoon. Bye.